So, in this clip, we're going to go through the base case hip-hop simulation model, trying to see exactly how this thing works. So, as an overview, Hipkins has 4 operating rooms and 2 anesthesiologists and 2 surgeons. This is partitioned into 2 tracks, the A track and the B track. There are 2 ORs associated with the A track, 1 anesthesiologist and 1 surgeon. Same is true for the B track. The idea is that the surgeon works in 1 OR on a patient with the anesthesiologist. When they're done, they pivot to a patient waiting for surgery in the other OR. And then while they're working on in the second OR, the first OR is clean. And so they're pivoting back and forth. And while they're working on the one, the other one's being cleaned. This is because their time is the most valuable, and you want to keep them as busy as possible. They seem to be the bottlenecks, at least conceptually. We'll verify that statement. There is a registrar pool. These folks are registrars, and they serve both pools. And then there's an EVS pool. These are folks who clean the ORs and restock with instrumentation. They serve both pools. Currently, there are 2 registrars. This is something you could experiment changing. And there are currently 3 EVS staff members in the EVS pool. So let's try and go through this slowly and understand what's going on in each of these tracks. But we start with patient arrivals. This is a source block. So I'm in the palette menu now, and this is the process flow library, process modeling library. And you can see what a source does. It just basically creates agents, which are, in this case, patients. And we do so every 90 minutes. The way I can see that is, just scroll along here, that is normal with a mean of 90 and a standard deviation of 10. Recall that the convention in any logic is standard deviation, common mean, when you have a normal distribution, and I'm modeling the inter-arrival time. Now, this is not set in stone. What we're doing is we're scheduling the patients to come in every hour and a half, and we schedule 2 of them, 1 for track A, 1 for track B. We're scheduling a total of 12 per day. If you eventually find a way to get more than 12 patients through the system, kudos to you, but you'd have to come in and control this maximum number of arrivals. All I'm able to get in the base case simulation is about 4, maybe 5 customers to complete in each track. And we do have a new agent type that we have crafted or created. It's the patient type of agent. The reason I've created different types of agents is because I have anesthesiologist agents and patients and EVS folks and surgeons and registrars. All right, so they're coming every hour and a half with a little bit of variation, and that little bit of variation recognizes things like couldn't find their way, traffic, late start, all of those kinds of considerations. So we're bringing it 2 at a time, and then I've got a splitting block here. That's just this splitting tool here, and I'm just splitting them so that I'll just click on that block so you can see the logic. I'm just directing them to the shortest queue. There's 2 queues here. These are folks waiting for registration, and they just get diverted to wherever the shortest line is. And if they're both empty, then there's going to be 1 going to each line. So you're going to ultimately see that there's the process time is actually slower than 90 minutes. So it may pay to actually slow that arrival rate down to 110, 120, maybe longer minutes, so that folks are not coming in and sort of like lining up here, waiting for surgery, but to sort of schedule them to arrive a little closer to the actual surgeries. It could be a way of reducing their anxiety also. Then I've got timers. But let's look at track A only because track B is essentially identical. So I've got a timer that starts here and ends out here. And the idea is to measure the time from the point of arrival to the time that the OR in which you received your surgery is finally cleaned. This is kind of, from beginning of the engagement on through, at least from the surgical perspective, the your process. Of course, you're going on to the PACU and recovery as a patient, but we're not measuring that. This is the flow time that we're interested in measuring. So this is just a regular timer, just using, let's see, it should be around here somewhere. Time measure start, time measure end, and you have to have these work in pairs, and time end, is connected to time start. And I'm able to generate a histogram of that by this thing in red, by using this data. I'm doing a float, a histogram here. And the key move is to use time end A. So that's the end of the time here, and then dot distribution. You can choose the color you want. Also want to show the PDF and show the mean. That's how we get that histogram. Unfortunately, there are not many executions here, meaning not many completions of surgery. So we're not going to get a very nice histogram. It's going to just basically have a few teeth in it representing each surgery that gets completed. All right, so that's the histogram. The patient comes in, and they go into. So let me just show you the blocks here. This one is a service block. Just see if I can find it. There it is. Now, service block does a few things. Let me see if I can just mouse over it. For some reason, that's not coming up, but you can try this on your own. It grabs the resource. So let me just show you the detail here. You are grabbing a member of or a unit of the registrar pool. That is a resource pool. There are currently 2 registrars in that pool, but you're waiting to grab one. So you line up, grab a registrar, and then there's a delay. And that delay is normal with a mean of 5 minutes and a standard deviation of 2 minutes. Once you're done with that, then the registrar is released. So the service block is actually a fairly complex block. And I was originally using that to model the anesthesiologist's contribution to the workflow, thinking that all they're going to do is the consent, the pre-op, and giving the anesthesia, not realizing that in fact they're going to have to stick around through the surgery. So I used a service block, and then it dawned on me that, oh wow, we're going to grab the anesthesiologist. There is going to be some direct engagement with the anesthesiologist for the prep and the spinal anesthesia, but then they actually only get released after the surgery. So you can see I had to sort of break apart the functions in the registrar of lining up, grabbing the resource, getting the actual registration done. That's a delay, and then releasing the registrar. I had to separate this out a little bit for the anesthesiologist, just because of how the process really works. Okay, so what I'm doing here with the SEAS anesthesiologist, this is this SEAS block. Where is it? Right here. And, for some reason, it's not popping up. Oh, there it is. It just grabs, in this case, one anesthesiologist from anesthesiologist pool A. There's one, SEAS 1 unit. That pre-op and anesthesia is given there. I'm saying that it's a mean of 25 and a standard deviation of 7.07. That's that lumping together of the pre-op and anesthesiologist consult and anesthesia that is shown in the case. Those familiar with this process are going to argue that nurses and other folks are actually providing the service. But as a simplification of the process, I'm saying let's just assume the anesthesiologist is the one delivering the service, and it takes a mean of 25 with a standard deviation of 7.07. Right, we're now going to grab an OR. We need 4 things to come together for the surgery to happen. You need a clean OR, you need the patient, you need the anesthesiologist to be attending, and you need the surgeon to be available. That's then and only then can the surgery actually kick off. So we're going to wait for an OR to be available. It could be being cleaned, and you have to wait for that. But that's the next block. All right, and then you go through the surgery. Now the surgery is the service block. it grabs the surgeon. So you have to wait for the surgeon to come. You've got the OR, you've got the anesthesiologist, and of course the patient is there. Now you're just waiting for the surgeon. When the surgeon is available, things that person is grabbed, it's 1 unit of surgeon, meaning one surgeon. And then the service time is 100.71 minutes. That comes a result directly from the proxy flow unit calculation, lumping all the BMIs together in Paul Carnegie's paper from 2019 with co-authors. And the 8.9 is just the weighted standard deviation of the surgery time. Right, then at the end of the surgery, the surgeon is automatically released, just as the registrar was released in this block. We then release the anesthesiologist. That essentially happens simultaneously. Once that surgery ends, it's almost instantaneous that the surgeon gets released and the anesthesiologist gets released. We've got another service block. So now we're grabbing a member of the EVS pool, and we're cleaning that OR. So we grab a member of the EVS pool, one staff member, and I've got this as a 40-minute mean completion time with a standard deviation of 5. The table in the case says 15 and 5, but again, I've talked you through that. That was more of a pre-pandemic number, and post-pandemic, the cleaning has slowed dramatically because of inexperienced staff that turn over rapidly. All right, so we're close now. The OR is now clean. We stop the clock and we release the OR. So it now is useful for the next patient. And then we take that patient to sync. Track B is the same. It has its own anesthesiologist, its own surgeon, but the tracks share the registrar pool to get the registrations done, and they share the EVS pool. The ORs are not shared, and that is one possibility. We probably cannot pool the surgeons, across the two tracks, put them two together into a pool because of that dedicated service requirement. But I don't think there's any impediment to pooling the operating room so that the surgeons could potentially do the surgeries wherever a room is available. There could be some concerns about which track they're on, and you might get a mismatch on that, but we will try it. We will try a pooling analysis and just to see if it works out. So just a note, there are two people in the registrar pool. There's one in the anesthesiologist pool A, that is the anesthesiologist dedicated to the track A, one surgeon, 2 ORs, and there are 3 people in the EVS pool that serve both tracks. This is also one anesthesiologist, one surgeon, 2 ORs. The histograms we've walked through, there are also utilization statistics being collected as you simulate for the 2 surgeon pools, the registrar, the EVS pool, the 2 anesthesiology pools, A and B, and the 2 operating room pools. So that is the model in brief.